everyone. I'm Lisa Palladino for Tongue Tie Experts, coming on tonight with two very good friends and members of my tongue tie team, Danielle Quinto and Christina Goodheart. Just want to apologize. We're a few minutes late. As always, Facebook and Zoom give us some technical difficulties trying to connect, but I think we're all here now and really happy to be with you. For those of you who don't know me, I am Lisa Palladino. I'm a nurse midwife and an IBCLC lactation consultant in Staten Island, New York. And I am privileged to work in one of the best places for tongue tie treatment because we have a great care team in our area, and it's growing as more providers learn about tongue tie and get lots of education and join the team, because it really does take teamwork. So tonight, I'll start with Danielle. Danielle Quinto is an occupational therapist and a TummyTime method provider. So Danielle, do you want to tell us a little bit about what you do?
Yes, so I'm an occupational therapist. I have, since the start of my career, I worked always in pediatrics. I worked with school-aged children for a number of years, and over the course of the years having my own children, I really started specializing. Hello? Oh.
Yeah, you're there. We see you.
I really started specializing in working with the pre-crawling baby, specifically with pre and post release and tongue tie and tethered oral tissue, and expanding my horizons and knowledge within that field. It's been such a pleasure working with Lisa and Christina, you know, to really collaborate and get the best therapeutic benefits for all the babies that we work with. So my other field is that I specialize is in sensory processing, and through the years learning about how sensory processing affects school-aged children, I now see how, with working with the babies, how working with them I could lay a really great foundation for sensory integration starting at infancy, and that lays a foundation for further development. So it's been such a great experience.
Yeah, so I love that, the connection of what we can find. You know, when we know what we know, we can see in babies what could potentially become what we're seeing in the kids we treat, right? So, I mean, I don't treat kids, but I observe a lot. Yeah. So that's great. That's great. And you don't mind me saying how we met, right? I mean, we met as,
of course not.
Forget about HIPAA. You were my patient because of your babies, right? So that's how we met. And to me, it's really heartwarming and just nice to know that somebody took a challenge that they faced with their own kids and realized how they could use their own career and help other babies. So thank you for what you do. And now a little bit about Christina. So Christina, me and you go way back, but you don't even realize it because I worked with your mom for so many years. And I heard about you since you were a little girl, followed you growing up, you know, all your achievements, hearing from mom. And then one day you appeared on the scene as this, like, SLP was learning all about tongue tie, which was like, I love that because there's so few in our area. And so tell me what your certifications are and where you fit in professionally with us.
So I am a board certified swallowing specialist, which is an ASHA designation. I'm also a certified kinesiotaping practitioner. And I've been working with infants for probably 2 years now through going to all different courses. I am in the process of becoming a certified oral facial myologist through the IAOM, and hopefully I'll have that by the end of the summer. So
see how excited I am about that?
Very exciting.
Yeah.
So I mainly work with adults out of school. I had very little bit of exposure in the NICU at Jamaica Hospital, and then I came to Staten Island Hospital, and I've been there for 9 years now. And then through private practice work and fee-for-service work, I was working with younger children with complex medical disorders and diagnoses, feeding disorders. And I really started getting into the ones that weren't being helped by the therapy that I had learned in traditional therapy. And I started taking courses from many different providers and trying to put it all together. And the course I took with the IAOM really put it all together for me. And that's when I got more involved in tongue tie and actually participating in children getting releases, doing pre-release work and post-release work. So very exciting.
Right. It is exciting. And I love what you said, because I say this all the time. The reason why I know about tongue tie is the same. I was trying all my tricks that I learned for breastfeeding help, and there was such a population of babies that weren't being helped by what I knew. And I was like, there's got to be more. And for those who don't know what tongue tie is, in case you've just happened upon this conversation and you've never heard of tongue tie, we refer to it as tethered oral tissues, TOTS, meaning tongue tie, lip tie. Sometimes we refer to buccal ties, which are the cheek ties. And what it means is restrictions on the normal. We have frenum in our mouth that attach the lip, the tongue, the cheeks in different areas. And sometimes they're either too short or too tight, and they prevent normal movement and normal function. So the three of us work with function, right? Which is fantastic, because if somebody just assumes that their baby may have a tongue tie and they're just examining or looking at pictures and thinking it looks like a tie, that's not really it, right? I mean, we find there's so much more to it than that. Christina, I bet you can speak on that, because you've seen that firsthand, especially, right? Those babies that, or kids, or even adults that you see that have oral restrictions.
Yeah, there's always a way to tell that there's a compensation. And that's where I feel like I got more into it, by realizing just getting it released isn't going to fix anything, because there's already like a learned compensation.
Right.
And I have gotten such better outcomes from my patients by doing that pre-work and identifying the compensations. People who have like a slight head tilt, or they slide their jaw while they're speaking, they may talk out of one side of their mouth, their posture, all those things can then influence the rest of the body's systems working. And in infants, there's not as much that you can kind of look at when you compare to an adult, but it's a whole system of assessment that Danielle and I talk about constantly, looking at how the baby positions when you lay them down. Do they tolerate from up to down? Their resting posture. Everybody is born as a nose breather, and if their mouth is open, they're not getting good nasal breathing. So it's very fascinating getting into the compensations and identifying them. And we always joke when we go out to dinner with my friends, who's doing what.
Yeah. So Danielle, you also do infant massage, right?
Yes.
Yeah.
So So when there's a tethered oral tissue in the mouth, it just affects all the patterns in the body, and different tension areas will come up because of the tension in the mouth and the tightness in the mouth. So you may, it affects the muscles of the face, of the jaw, of the neck, of the whole entire body. So we're not only, when we talk about tethered oral tissue, we're not only talking about what's going on in the mouth, but we want to see what's going on in the entire body. So I'll get into the TummyTime method after, but as far as infant massage, it's just such a wonderful therapeutic tool for parents to do with their baby. First of all, it's a great bonding experience. And then it also provides a lot of tactile stimulation, and it helps release any tension in the bodies. It gives elongation to the muscles, to the fascia, to just the entire muscle and the whole sensory system, the skeletal system. It's just such a wonderful therapeutic tool. So there are different massage techniques for the face, for the upper extremities, for the chest, for the back, for the legs, the lower extremities, all the way to the feet. So that will just help release the tension, which if there is tethered oral tissue, there's going to be tension within the rest of the entire body that has to be worked out even before we talk about the release.
Right.
Any baby, and it's not only babies with tethered oral tissue that can benefit, it's every baby who's coming out of the womb could really benefit from infant massage.
Right.
So that's such a wonderful tool, when I teach it to the parents, because the parents are going to be doing with the baby. you know, throughout the week. And I think we could all say that whatever we do, we're educating the parents to take these tools and to do them every day, because it's you, the parents, who are going to make the biggest difference.
Yeah, I think that's an important point. There's so many things that, you know, especially if a baby's having some problems, there's so many things that parents feel out of control, right? They've just had a baby, they're, you know, maybe hormonal things going on or light health problems. And when we give the parents something that they can be in charge of, I think it's empowering and helping them feel like they're a part of it, because it's the whole point is getting the mom and the baby, or the parents and the baby, together and functioning well.
Right.
So that's
and that connection and making that connection. And
I bet you that moms release oxytocin as they're doing the infant massage too, which helps with breastfeeding. Right? So I'm just going to look. I just want to say, if anybody's watching and they want to ask us questions, I'm trying to look on Facebook and see our questions, because you can just post anything you'd like to. I am like not having the best technical day today. Let's just say that. Nothing is really working for me. Facebook is coming up and the questions aren't showing, but I will find it.
I see one question posted.
Yes, I see that now too.
Okay.
It's working. Great. It was stuck. My newsfeed wasn't going. So the funds of Facebook. So what I love is, you know, in the process and what I call it preaching or teach about tongue tie, is that it's not just about that piece of tissue under the tongue holding the tongue in its place. It's about the function, right? And then it's not just about, as you say, if we release this, I think Christina, you said it before, it still has to learn to work. So even if the problem isn't just the tongue tie, if the problem is tightness somewhere else or weak muscles somewhere, we release the tongue and there's no improvement, because if that's all we do, that might not have been the main problem. Right. I'm sure you see this too, Christina, right? And that's the reason for the pre-work, especially.
Yes, it's definitely so important. Even as young as an infant, getting it done, you know, 1-2 days old. You want to make sure that the parents are prepared to do the exercises or, you know, techniques, stretches, whatever. Everybody calls it something different.
Right.
But stimulation in the mouth so that they are not defensive, and to prepare them for the release, which is a wound. So it's going to make a wound and it's going to be uncomfortable for them. So getting them desensitized, at least to going in their mouth, is such important preparation.
Absolutely. So I like to differentiate, and in my course, I describe it this way. For those of you who don't know, I do have a course called Parents Guide to Tots. We'll be posting that, and we're going to be posting everybody's websites and contact information for those of you who want to get in touch with us afterwards. I highly encourage signing up for, you know, our Instagram, our Facebooks, and emails if you're so inclined. But in my course, I preach, or I teach, see, I keep using that term, preaching, about the difference between stretches. I call them stretches and exercises. So stretches I refer to as the wound care. So keeping that wound open because we don't want the wound to heal too fast. And then the exercises are to get the tongue moving. And I like to separate that. And I like parents to start the exercises before the procedure so that baby's used to the play. And that the exercises, no matter what they are, and sometimes it doesn't matter what they are, it's just about getting the baby, like you said, sensitized to having a finger in the mouth when it doesn't hurt, right? Mm-hmm. And then I usually say, and I may be, you know, wrong about this, but to do that at a separate time than the stretches after the procedure, like not to do the stretches and the exercises at the same time, because I always feel like it's important for babies to have that playtime when mommy's smiling at them, and the stretches hurt. No matter what you say, the stretches hurt. No matter who says there's no pain, it's painful. And when we're doing the stretches, it's going to hurt. It's only for a few seconds, but it's going to hurt. And if it only hurts when mommy plays in their mouth, they're not going to want anything in their mouth. And I've had a pretty good, knock on wood or something, I really haven't had oral aversion for any children done by the provider we refer to, and done in this way with separating the exercises and the stretches. Is that something that you'd agree with? Do you recommend similar?
I do, especially the first 2 days. They're so sensitive from it just happening. Most of the older kids who can report, they start to say by day 3 or 4, it's not that bad. So I'd like to say that translates too for the infants, but you know, they do associate that stretch with discomfort. So having good oral play throughout the day that doesn't hurt is so important.
Right. Yeah, totally agree. And then we have the whole issue of the Back to Sleep campaign and why we even need tummy time method. So Danielle, maybe you can speak about that, about, you know, why we need tummy time method now, because we've had such a backlash and people are afraid to put their babies on their belly, and
Right.
it's sad, but maybe you could talk a little bit about that.
Yeah, and you know, I think pediatricians are aware that because babies are sleeping on their back, the pediatricians do recommend put the baby on their tummy, which is, you know, everyone is aware of that. But the tummy time method was developed by an occupational therapist, Michelle Emmanuel. She specializes in working with pre-crawling babies. So she developed this method of how to totally and fully and holistically engage the baby in tummy time. It's not just putting the baby on their tummy and making the baby struggle, because it could be very challenging, especially right from birth. So the tummy time method was designed to engage the baby sensory, you know, a total sensory motor experience, laying the baby on their back, rolling them in and out of tummy time, engaging them. And then once they reach a point of frustration or a point where they need to come out of tummy time, to know that you're able to roll them out and lift them back up, and then repeat it that way so that you build up the, you know, the tolerance to tummy time. So it's a way for the parent and the baby to really enjoy the experience of tummy time. So the tummy time method has 8 phases of doing the whole method. So, and then throughout the day, you're doing the tummy time method, not just putting the baby on their tummy, you're doing the whole tummy time method 3 to 5 times in one day. And at first, you know, it may be difficult for babies, but you're going to continuously do it so that they could increase their tolerance in a very fun and loving, nurturing, therapeutic way. So that's why I, you know, as an occupational therapist, even in school, when my nieces were born, I just had the same mentality of tummy time, let's work up to 15 minutes, 3 times a day, 15 minutes. It's really the tummy time method. And then once I had my own children is when I started learning about the tummy time method and seeing how much more therapeutic it is. And it's not about the baby struggling and using those muscles in tummy time, it's the whole sensory motor experience. And also, you know, there are different activities that you could do while the baby's in tummy time to help elicit some reflexes that should be present, and then to do exercises so that those reflexes become integrated. So the baby has to use their body in different ways, in different positions, to elicit certain responses so that things get integrated, and then they could develop further developmental milestones. That's why I love the tummy time method, and it's such a fun way for the parents to bond without it being very stressful, because you know, I have friends who tell me, you know, or clients, you know, tummy time method, it's not the tummy time, just tummy time in general, before they know the tummy time method, it's stressful because the baby cries and they don't like it. And, you know, they're worried, they're nervous that the baby's head is going to, you know, so a lot of things come up. But once the parents learn the tummy time method, it's so much more enjoyable for the baby and for the parents. And then if they're siblings, you know, once I had another child, you know, the whole family got involved in it. So it becomes such a great tool. And it lays the foundation for the future, you know, for further milestones. And then when there's tension in the mouth, you know, the being on their tummy and getting that sensory experience will help open everything up also, and release any tension patterns that are going on in the neck, in the body.
What I find in my practice is that babies that have tight oral restrictions have a harder time when their moms put them on their bellies. So that definitely is related to all the fascia connections and everything.
Right. And one of the main things with the TummyTime method is active movement. So the way a lot of the tension patterns do release in the body are from active movement. So with the TummyTime method, you're putting the baby in different positions and stimulating the baby to actively move. We're not passively stretching different parts of the body. It's all the active movement. And when babies are born, they're in the fetal position in the womb. So they're very, with or without tethered oral tissue, there's going to be tension patterns within the whole body. So it is very important. And tummy time should be started from birth. You don't wait a few weeks. From birth, there's ways to modify the whole method to have the baby initially start, experiencing the movement of the head back in space, the rotary movement, full body weight bearing on a flat, firm surface is very important to development. So that's another area that, we work on. And the way that the baby develops is head to down. So you want to develop the head and neck control, and working up against gravity and playing with gravity, because when you're in the womb, there's no gravity. So then when you come out, now gravity is acting on the whole sensory system, and now you have to work against gravity or with gravity in different positions. So it's really important.
Yeah, it's something that, I don't think we think about that. That's interesting. There's no gravity in the womb, right? They're just floating around. It's like being up in space.
And they're getting a lot of.
I know we're having questions that are coming in, and we'll get to them. But what I wanted to bring up with Christina is one of the ways that I've needed to reach out to you is because I really didn't have a lot of training in how to select a bottle for a baby, and a lot of babies with tethered have a hard time transitioning to bottle, or some won't take a bottle at all, and you're the one I call when that happens. So do you have any general hints for for families about bottles, or is there a specific bottle that you recommend in general, or is it specific, or does it depend on the baby?
It really depends on the baby. The different types of nipple shapes depend on what's going on inside the child's mouth. So what I've been doing is doing the evaluations and asking the parents to bring anything that they have, because I find by the time they call me, they've already tried 5 bottles anyway. And then we do the evaluation in the child's mouth, and then we look at the bottles that they have, and we talk about, do you have a personal preference for one before I explain which one I think we should try. And then I show them different ways to try to introduce the bottle. I did a lot of reading up with Diane Barr and her books and her webinars.
I love Diane.
She goes into detail about knowing the shape of the mouth and what the tongue is doing versus the shape of the nipple. And then usually I haven't had so far a child leave the first session without at least latching on the bottle and doing something functional. So then I send the parents home with homework about trying to adapt it. So one client was exclusively breastfeeding and trying to introduce the bottle, and the child was having a very hard time. So we introduced it as like more oral play with the bottle for up to an ounce until the child got the hang of it. And sometimes the children pick their own bottle. I had a few where the texture of the nipple made a bigger difference for that child than other children I've evaluated. They would not tolerate the other smooth silicone. They would only tolerate the textured, like mimicking the skin nipples. So far it hasn't gotten to where I leave the evaluation saying you have to go buy this bottle, but usually you can try to work with the child's mouth to get whatever bottles they have to adapt. So a lot of people really like Dr. Brown's, and they are easy to hold. The wider ones can be a little uncomfortable if you have to do any kind of postural things with the baby, feeding them upright or doing chin or cheek support. So, but it's been working so far to say, bring everything that you have, and then we'll just see what we can work with.
It's interesting about the texture, right? I mean, that wouldn't be something I would have thought about. Very interesting.
I always thought it would make a difference, but I never saw it until this kid still, it's probably been 2 months and they still won't take the smooth textured nipple. And, you know, it's not something that should make or break it as long as they're getting the nutrition they need, they're spitting up less, we're getting better functional outcomes, and it's less stressful to do feedings, because that can carry through with the child through development. If we make feedings too stressful for them, it creates more resistance and displeasure, and they're not going to then smoothly go through the developmental milestones that they need to.
Such an important point about that the feeding experience should be as peaceful and, you know, unstressed for mom and baby, whether or not it's bottle feeding or breastfeeding, right? It should be an enjoyable experience. Okay, so I'm going to start reading some questions. We have one from Jessica. Jessica asks, why are tongue ties so much of an issue now? Is it true that we all have the skin in our mother's womb, but not everyone's dissolves? Oh, in other words, that it is there before. So what I know about it is that it seems to be an epigenetic change, and somebody in the comments mentioned genetics, possibly because of a few years or a few generations of not breastfeeding, and our mouths are not only not breastfeeding, but not chewing, not using our faces the way we're supposed to, not developing the airway in the shape of our mouths. So that's possibly it. It could be that this issue was there, you know, maybe 2 or 3 generations ago, and we weren't noticing it because there weren't people breastfeeding. It's not new. There's always been tongue tie. It's even mentioned in the Bible. So there's always been tongue tie. It just seems to be more prominent now. My own theory is it's possibly, you know, part of the epigenetics could be because of the toxins in our environment too, and as far as it being in the womb, there's something called apoptosis, where the cells that don't need to be there actually go away, and if that doesn't happen, you're left with a remnant. So that is true, Jessica. So what else?
I was always interested in that. They said the releases have been around for hundreds of years too. They have documented the procedure itself.
Yes. Of course, they didn't have lasers, right?
Yeah.
So Zavori says that she's working with therapists for her 7-year-old's tongue tie, and hopefully it will work. So we could talk a little bit about, you know, I just deal with breastfeeding babies, but we can talk a little bit about, because the both of you work with older kids, and how different it is, the approach to a breastfeeding baby. Often the breastfeeding release is almost an emergency if we can't get the baby to eat at all. But when there's an older child, there's more to consider, right?
Definitely. It's all about timing. You're preparing for the release and timing the release and trying to maximize any function you can. You know, with an infant, you're trying to do the same thing, but it's on a different scale. Once they're older, their teeth are coming in. You have other complexities that sometimes influence it, their attention, their allergies, if they're congested. And by then you may have other structural anomalies, deviated septum, their tonsils, their adenoids. And, you know, there's always back and forth. It's not easy to say blanketly, like some providers do, let's just remove the tonsils and the adenoids because they're obstructing the airway. You still have to try to work on function as best you can to see how you can improve any of those factors.
Why is it that we're so quick to take out body parts?
It does immediately help with the breathing, you know, right away they have better scores. And there's a lot of research studies they've done even on adults with sleep apnea, where the surgeries look great for the first year maybe or 2, and then after that people go back to having a lot of difficulty, and they couldn't really figure out why. And a functional approach really does help and increase the ability of the body to compensate better. And I have had some patients, all different age ranges, where they were referred to me because someone told them they needed a release. And we did the therapy and they were happy enough with the results that they didn't want to pursue the release then. So,
Right.
you know, that you have to respect their decision, because it's not really a black and white issue. If
Right.
all of the symptoms go away, then a release really isn't what's most appropriate at that time. It may
Right.
come up later, adulthood, orthodontics, but a lot of people are finding that if they do a lot of good intervention while the children are younger and promote good mouth development, they're not really needing any orthodontia.
That's great. Yeah, and I know when I took a very short myo course just to have the background and understand what it was. And what we were taught was there are certain signs to look for the readiness for the release, right? So if we get that done too fast, it may fail, and then, you know, it feels like I wasted my time. Why did I do this for my kid? So I think to answer our question from the Zavori who posted, I think that's a very good idea that you're working with therapists before the procedure. You definitely will have better results, or at least know that you gave it your all for your child. You know, it's a very complicated issue, but you know, the more professional and experienced help you have, the better the result probably will be. Nicole, hi Nicole, are you still here? Give me a thumbs up. I haven't seen you in a while. She says that her 3-month-old hates tummy time and cries every time, so this is great to know. Thanks. So that's something that not everybody realizes, that restriction carries through the whole body. Oh, and Nancy is here. Hi, Nancy. We all know Nancy's another feeding therapist, and Paul Bond. Hi, Paul. Paul is a dentist. We've got great people saying hi here. And we have Christina saying her 15-month-old will be having the surgery in 3 weeks. Great. So I think that's all the questions that we have going on there. Let me just make sure. If anybody has any other questions, you know, definitely keep adding them. And if we don't answer your questions during the broadcast tonight, we will go back and look at it and go through it and make sure that we got to your questions. And if you're seeing this recording after the fact, because it'll be up for a while, it'll also be on the YouTube channel, feel free to message, you know, any of us with any questions that you have. I just want to mention, you know, I always come off this and I forget to tell people about all the things we have available to us. So Christina, you're in private practice out on Staten Island, correct?
Yes.
So you are available to treat all ages in private practice now, and specializing in babies. What's your, you know, what do you prefer or see usually?
I see, usually in private practice, I see infants through preteens and teens. And then at the hospital, I see adults with sleep apnea, TMJ, stroke patients. Interestingly enough, I've had a few stroke patients with pretty severe tongue ties, and they were able to participate better in therapy after they got released.
Wow.
So that amazed me a lot. That was a surprising thing that I learned, where I started thinking back to other patients I had that were adults, you know, that didn't do too well after a stroke with their expressive language skills. How many of them did I miss that on? Right. So in private practice, I have 2 offices right now on the island that I'm working out of, one on South Avenue, and then I share space with Danielle on Pear Place.
Great. And Danielle, your office offers not only classes, but private, right? So tell us a little bit about that.
Yeah, so we have TummyTime classes, which right now are by appointment only, but in the summer we're going to have a bigger schedule for our TummyTime classes, and those are drop-in right now. And then we're also going to have 4-week series where each week will be a different topic to discuss on top of learning the TummyTime method. Mm-hmm. And then I see individual private sessions, you know, infants all the way up to school-age children.
Right. And the 3 of us are in Staten Island. For those of us who are mentioning addresses, Staten Island, New York. Mm-hmm. There are more questions popping up. Beautiful. So Klaus says, how to keep the ties fixed? I'm seeing babies that after the surgery, the tides come back. The ties come back. So I will answer that. First of all, sometimes it heals and it looks like the frenum is there, and that's not necessarily reattachment. We want to go by function. So I would say think about what the issues were that caused you to have the procedure. I like to list them for parents usually, and then judge how the release is by how many of those concerns were solved. And so say it was painful nipples, and you have the procedure and the painful nipples go away, baby's opening his mouth nice and wide and everything seems better. If you look under the mouth and you still see that frenum, it's okay as long as the nipples aren't hurting anymore and the baby's still transferring milk and all the other things are there. So if a baby can't latch and now they're latching, we solved it. If a baby was having reflux and now they're not, even if you see a new frenum there or the replacement, there's a form, without getting too technical, the frenum grows back. It's a different type of tissue, but it does grow back. Not necessarily reattachment. It's more of a functional diagnosis, even for that, whether or not it's reattached or not, which is why it's so important to work with a functional provider that's assessing the function, right? Okay, let me just say, can tongue tie cause speech delay?
It can definitely interfere with speech production, and there are some studies that support that it does impact language development, that it can hinder leaving the restriction in the mouth, their language development as well.
Yeah. I like to tell parents that some kids with speech delay have a tongue tie, but not everybody with a tongue tie is going to have a speech delay.
Yeah.
We don't know. We really don't know.
And that has to do with the compensations. If they really learn to compensate for speech, there may be other symptoms of something else going on from the restriction, but it might not necessarily be speech.
Right.
A lot of times that's why my evaluation, I see how they're eating and how they're speaking. And I look at just their function and then make a treatment plan based on that. Instead of separating everything, I kind of try to do it all together.
That's so important. So the other thing that I see often in babies that are a couple of months old, I'll see the parents will say, oh, they all automatically started cooing afterwards. They weren't making noises, and all of a sudden they're babbling and cooing and all that. That's all so fun. Okay. Christine is on. She said, so many Chris's, right? Christina, Christine, Christina. Pediatric OT here. Did the surgery with Dr. Siegel. Baby ate an ounce more per feeding immediately following the procedure. That's great, Christine. That does happen. And Lauren says her almost 5-month-old had his lip and tongue tie released at 3 weeks old and is exclusively breastfed and has done really well with TummyTime, but has always refused pacifiers and will play with a bottle but not drink from the bottle. Is there a certain age a bottle should be introduced by? What a good question. So what do you think about that, Christina, in your experience?
I mean, I've read people expressing things on both sides. Up to 4 to 6 months, they should have oral play of non-nutritive sucking. It's something that they seek to regulate themselves. And usually, I feel based on the functional side, we should be able to accept anything. If they can accept a pacifier or a nipple of a bottle and the breast, then they're having fairly good function that they can do all those things. So I have worked with some parents who really want the pacifier when the children are younger to try to get them to be able to accept it. Usually they maybe have a thrusting pattern. Their tongue isn't cupping as well. When they're not on the breast is prompting them to cup, but when we look at them on the bottle or the pacifier, you can see that they're really not cupping it and they're kind of pushing it back out. Pacifiers come in many textures compared to bottle nipples, so those different textures make a difference too. Some babies will gag on the smoother textures or the oval, oblong nipples as opposed to the tiny or straight pacifier nipples. So playing around with whatever the parent has and trying to do any kind of techniques in the mouth to stimulate good oral play, like suck training, having them suck on your finger, sometimes that can push them along to then have them accept it. And then on the other side, some people feel they should never, ever have a pacifier. So
I like to say that the only providers that really love pacifiers are orthodontists. But I say for emergencies, you know, I don't want a baby to ever cry. So you're in the car, or, you know, mom's taking a shower and dad's watching the baby and the baby wakes up screaming. Better to have a pacifier than let the baby scream. But I don't, you know, as a mom who had 2 babies who didn't ever want to give up their pacifiers, if I did it again, I would not be introducing a pacifier personally. Let me just look. There's so many questions.
it is interesting though. I have heard some presenters speak that even if you don't give the pacifier and they have that really strong desire to do non-intrusive sucking, they'll find something else.
Right.
And sometimes it could be harder to break that habit. Lip sucking, tongue sucking, finger sucking, digit sucking, thumb sucking, all those different things can then affect the mouth development as well. So I feel like it's good to have structured oral play with the pacifier where you have a goal of maybe starting to phase it out between 4 and 6 months.
Mm-hmm. Okay. Yeah, before they know how to ask for it. So I have another question from Kim. Kim is a lactation consultant, and she says, how do you respond to a pediatrician who tells a mom it's not a big deal to do anything about the ties? Mom is struggling with latch and milk production. Oh, Kim, this is so common, and it's very frustrating, and I feel your pain. Sometimes what I do, or I say to parents, because a lot of times when the pediatrician makes a comment like that to a parent, they may not trust you, but they don't have as much confidence in us as lesser providers, if you want to say that, or you know, the doctor is the runs the show. So if the pediatrician said no, then it's not a problem. Well, I like to say, well, can you ask the pediatrician what's their idea to feed the baby, right? What's their idea to get the baby? You know, do you believe in breastfeeding, right? You believe that breastfeeding is the best for the baby. So what's your idea for that? And put it back at them that way. The other thing is that I like to empower parents to find the pediatricians that support their choices. You know, I don't think anybody should be with a pediatrician who doesn't think that their choices are important, especially when it comes to something that we know for sure how much, you know, it's the natural way to feed your baby. So if the baby's not able to even compensate enough to breastfeed, then what's their plan for the baby? And you know, there's so many pediatricians. That's the other thing I would say. Okay, let me see if there's anything else I missed here. Oh, my friend Lisa is here. Hi, Lisa. She's a lactation consultant too. And she does myofunctional too. Okay. All right, I think the only other part of that question that came up about we talked about the pacifier, but the bottle feeding. Now this is really controversial too, because, you know, if you want to be, there's the whole mindset of a baby should never, ever, ever have a bottle. But many of us are needing to give our babies bottles. In my opinion, when the bottle is introduced doesn't matter, because I think I've seen kids have a bottle day 1 and then at 4 months old refuse a bottle. I don't see a relation for when the bottle is introduced. But do you see anything different in that, Christina? Do you think a bottle needs, like a baby needs to learn to use a bottle so they don't not use a bottle? I don't think that's true.
I don't think so either. I think it really does come down to their function. And I think that the bottle provides some relief from the parent. You know, there can be a heavy burden on children and the mom having to feed them with breastfeeding. And sometimes they feel like the bottle is their relief from getting a break.
Right.
And then I've actually heard dads say they feel left out, that they can't feed the baby, that the mom gets to feed the baby all the time. So I think a bottle is an important tool, but I don't think that the timing of introducing it should make a difference for most kids.
Okay, that's good. I agree with that. whatchamacallit, the other thing that I didn't want to forget to say is that very often we have people who've watched this on Facebook, and not everyone's on Facebook. So there is a YouTube channel, Tongue Tie Experts, and we'll be posting that in the link. So if anybody wants to share that or sign up to be, you can sign up to get notifications for Tongue Tie Experts YouTube channel. And that's a great way to share anything that you've seen, any of the talks that we've had, because we've had some really cool things. I had somebody ask about oral aversions in older kids, and older kids meaning few months old. So I would like to say that I've never seen a true oral aversion in a child who was released by a provider knowing what they were doing. So, you have to be careful who the provider is. If it's not done properly, and the tool matters, in my opinion, and I haven't seen oral aversion done with a proper laser, with a dentist or a doctor who's properly trained to use that laser. I don't know, either. Have you seen any oral aversions, Danielle?
No, I was going to say doing the exercises before will help integrate, the sensory experience going on in the mouth. So if the baby has no work done in the mouth prior, that first experience in the mouth is going to be aversive to the child. So, that could be one reason why, but I haven't seen oral aversion.
Yeah. I mean, I know it exists. I know it has happened.
I've seen babies before the release a little bit.
We're losing you a little bit, Danielle. Yeah, I haven't, maybe Danielle is frozen. Maybe she'll come. There she is. We lost you for a minute. You were saying you've seen babies before.
So before, once we start with the therapy, I've seen babies a little bit sensitive to getting inside the mouth, and then we have to work, up their tolerance to accepting, the different textures in the mouth prior to the release. But once we take care of that and help with the integration of the tactile input in the mouth and the oral, the movement of the tongue, then they have the release, and after it's usually fine. So because it's all sensory experiences, so if they're not getting that input inside their mouth prior to the release, it's going to be a bigger issue after the release.
Yeah. And also, there are kids who have sensory issues. So the problem may not be the tongue tie, right? We learn later that things happen, or, they may be tending to neurological sensory issues, and it may first show up as what seems to be an oral aversion, because feeding is their way of expressing themselves as newborns. Right. So yeah, that's interesting. But I haven't.
And then, when it's true oral aversion.
Yeah. I have seen babies that won't take a bottle, but they'll breastfeed. That wouldn't be considered oral aversion. I have seen babies that came to, if babies who've been forced to feed, like, there are some, let's put it this way, sometimes in the hospital, if a baby is sort of just like plugged into the breast and their head held on and whatever, I've seen in the hospital, second, third feeding babies wanting to pull back. So letting the baby find their way to breast, doing lots of skin to skin in the beginning and letting them root to breast. I've always found cures that and makes it easier. We don't want to put the baby on the breast, we want the baby to find the breast. And then they're in charge of themselves, which is really, that goes along with all the tummy time theories too, right?
Because if it's a stressful situation, they're always going to pair that experience with stress, regardless of what it is, throughout our lives. So, and babies are very, vulnerable when they're born. So if, they'll pick up on that even as infants. So
the one thing I want to say before we go off is how we work together. So not every baby needs every therapy.
Right.
But as the IBCLC, I have, you know, yourself, Danielle, Christina, I have physical therapists, I have chiropractors, all on my team. So if you're a lactation consultant, you're the one that knows, you're the one that's seeing the mom and baby together. And usually the first, you know, reach out is to the IBCLC after the pediatrician. So I think it's important for all of us to find our teams and know who we have to refer to for certain things. So, you know, I'm not referring to all my babies to Christina because not all my babies need Christina, but there are some babies that, you know, I've done my tricks and it's not all working. So then I call Christina. And in my opinion, everybody would see Danielle before because those methods work for everybody. Even if there wasn't a tongue tie, everybody should see Danielle. Everybody should see a chiropractor. I practice. My family uses chiropractor. Everybody should see a chiropractor. But there's specialized roles, and that we've gotten to know each other. We've learned together. We discuss, you know, we do like patient discussions together to learn from each other's experiences. And what we've built here is what other lactation consultants and other SLPs and other OTs can have all over in their own little areas.
Yeah.
So that's one of my goals of the Tongue Tie Experts page, is to bring people together. So not only can parents learn about what we do, but other providers can find each other. So if you haven't liked my page, Tongue Tie Experts, please do that. And I say Tongue Tie Experts, I don't want anybody to think I'm the tongue tie expert. It's about bringing experts together and learning from each other. So please like the page and sign up for the emails if you can. What I want to just mention one more thing before I sign off. If anyone's listening to this live, on June 3rd, I'm going to be doing an Instagram live for a company called Legendary Milk. Has anyone heard of Legendary Milk? They're not sponsoring me or anything, and I don't do sponsorship, but I just have to mention them because they make herbal products that make me happy, and not too many products make me happy that are manufactured. They're a really nice company, and they invited me to do an Instagram live. So that'll be my first experience with Instagram live, so that should be fun. So if you want to check out Legendary Milk, they make great products for mom's milk supply support. No magic pills, no lactation cookies. It's all about nutrition. So thank you so much, Christina and Danielle, for joining us and for having patience with the technical difficulties. And for everybody who listened tonight, thank you so much. Continue, you know, if we have any questions, as I said, we'll be going back and we'll be answering them, and have a nice discussion underneath. We had a great audience tonight. Thank you so much for coming. Anything you'd like to add, girls, before we sign off?
I'd just like to say it's been such a lovely experience working with you guys, as well as Danielle and I have taken some of the complicated cases and evaluated them together so that we can discuss them at the same time and make a good plan about who is most appropriate to focus with the child. And I think that would be a good tool for other providers to try to tap into. If you can find another licensed provider or skilled provider to work in conjunction with at the same time with the same kids, you really do learn a whole lot more. And it helps you identify when to refer and where to refer, because not one provider can help one patient. It takes a team for many, many different things.
Yeah.
Perfect.
Yeah.
Perfect.
And just to add that every baby, every child, every adult is different, and every child needs an individualized plan.
Yeah.
You know, a therapeutic plan as to what should happen first, you know, after, and just to maximize and optimize function in their everyday life. So it's just been a very great pleasure working with both of you and all the babies that we're working with also. So thank you.
Oh, you're welcome. Thank you. And we'll sign off and say good night. And let me just end this live video. Good night, everybody. Have a great evening, and we'll see you soon.
Bye.
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 Bye.